So the study that we're presenting here addresses the unmet need of patients with diffuse large B-cell lymphoma that has progressed after CAR T-cell therapy. We know that CAR T remains a very important treatment for patients with relapsed or refractory large cell lymphoma, but despite this, cure is uncommon, with only approximately 30% of patients expected to be cured by treatment with CAR T. Patients who are failed by CAR T-cell therapy represent a significant unmet need, and there is no clear standard of care for how best to treat such patients. Our data here from the ELM-1 study represent the largest and clearest prospective data set for the use of bispecific antibody therapy to evaluate the hypothesis that such treatment could be effective and safe in patients with large cell lymphoma progressing after CAR T-cell therapy. So the study design here is drawn from a cohort within the ELM-1 study, being odronextamab, a CD20 by CD3 bispecific antibody, as monotherapy in patients with multi-relapsed or refractory large cell lymphoma. Treatment with odronextamab was as per its standard treatment with step-up dosing, and the study was modified during the conduct of the study to instigate a more gradual step-up dosing to further mitigate the risks of cytokine release syndrome. Treatment was administered as per standard with weekly and then every 2 weeks until up to cycle 9. Patients who achieved a complete response at cycle 9 could be continued at a Q4-week dosing schedule until progression or intolerance. I would say the results here are encouraging. We found that in this heavily pretreated patient population, with this treatment being the median 4th line of therapy, in patients who had already been failed by CAR T as the enrollment criterion for this cohort, we saw that odronextamab monotherapy was active, with a best overall response rate of 48% and a complete response rate of 32%. Further, we saw that patients who had CR were likely to sustain that CR in ongoing follow-up. Responses were not just common, but also with a median duration of response of 14.8 months. And for those patients achieving a complete response, the median duration of complete response has not yet been reached at last data cut. We saw the treatment was safe as well, with a low rate of grade 5 adverse events of only 3%. Serious adverse events were common, but largely those which are expected from engaging therapy. Cytokine release syndrome was seen in approximately half of patients, but was almost exclusively to grade 1 or grade 2, and during step-up administration. We did see that there was a relationship between time from CAR T-cell therapy and likely effectiveness of odronextamab therapy, with patients who had progressed within 90 days of treatment with CAR T-cell therapy less likely to respond to odronextamab, with only 20% of such patients responding to odro. Whereas for patients who had relapsed more than 6 months after CAR T-cell therapy, enjoying a very high overall response rate of over 80%. The clinical impact here is that it is the first and clearest signal that for patients who have been failed by CAR T-cell therapy, relapsing subsequent, bispecific antibodies do represent a safe and effective strategy for treating such high-risk patients. There's obviously work ongoing with odronextamab in combination with other bispecific antibodies as well, but the study data from ELM-1 very clearly point the direction that bispecific antibodies are a relevant and encouraging strategy for these difficult-to-treat patients.